Thank you very much for asking me to talk today. I'm going to cover not only female radiotherapy, but I'm going to mention the men as well, because some of the things that we do to them cause problems with their sexuality, and that impacts on any relationship that they might have. So what is sexuality? Sexuality is the combination of people's gender, their sexual feelings for their others, their feelings about themselves as sexual beings, their orientation in sexuality, and their actual behaviour. Radiotherapy impacts on sexuality in many ways, and we have to consider things such as the age of the patient, the gender, the physical changes that go with both the surgery, the radiotherapy and the chemotherapy, the seriousness of the diagnosis. Patients are very worried about the fact when I see them that usually they've got a cancer and it could kill them and shorten their life. And their priorities at the time we see them is often about survival. It's not till they actually get over their treatment that they realise that they've lost a lot of their normal sexual behaviour, their companionship and feelings within their relationships, which has been upset by their treatment. We also have to think about the site of the treatment. It obviously makes a significant difference if you're treating in the pelvic area or the breast if you're a woman, or in the pelvis and testicles or prostate if you're a man. A diagnosis of cancer and the associated distress has a significant effect on the emotional status of both the men and women in a relationship. The psychological impact combined with the physical sensations of the disease itself, the treatment side effects, lower both the interest in sex and in the frequency of sexual activity. Age makes a lot of difference with the patients I see. My older people may have less need to consider their sexual behaviour in their assessment of their treatment. Intimacy and support, however, remain really important. And I had an 80-year-old patient the other day who asked me if I could ask his wife to remind her that he needs a cuddle every now and then, please. And he was obviously feeling she'd cut off from him, isolated, and he just needed her to know that it was all right, that it wouldn't infect her, that she wouldn't get cancer from him, and that he needed a hug every now and then. Younger patients, however, often ask about sexual behaviour and also fertility, and younger patients are also much more likely to raise the issue with you when you're having a consultation with them. Gender makes a difference. Pelvic radiotherapy in males and females is different, and they get different side effects. But you need to separate, when you're talking to the patients, the issues of intimacy, sexual behaviour and fertility. They often get quite mixed up in their minds and they're not quite sure what you're talking about. And it's very important to separate them out and go through it carefully with the patients. Not every cancer survivor cares about remaining sexually active, but long-term sexual dysfunction has been documented in about 50% of those treated for breast, prostate, colorectal or gynaecological cancers. That's a significant number of people who potentially could be helped in dealing with this and improve their quality of life if we deal with the issue. Not going to, but some of our speakers will address some of these issues later on today. Females, what happens to our women? Gynaecological cancer and its treatments have a profound effect on sexual functioning in all phases of the sexual response cycle, on body image, how they feel and look about themselves, and about how they feel as a woman and a partner. A diagnosis of cancer and the associated distress have a profound effect on the emotional status of the women and the partner, and that will impact on the physical sensations of the disease itself, the treatment side effects, and all the other things that are happening with the patient will reduce their interest in sex and frequency of sexual activity. And very often during a course of radiotherapy, the last thing on the mind of the patient is in fact sexual activity, and it's often not till after that they'll raise the issue. Side effects, as Ari's already pointed out, radiotherapy to the pelvis results in menopause. The ovaries stop working. They get a vaginal stenosis, and I'll talk about treating that. They get vaginal dryness, and that makes sexual activity uncomfortable. They can get pain and discomfort when they're actually having sexual intercourse. But as a result of the diagnosis, the treatment process, they can get quite depressed, anxious, and they get very stressed about the whole process of what's going on with them. And we have to help them deal with this. Fatigue. The fatigue of radiotherapy can be quite persistent. It usually gets better fairly quickly, but some people find that it can last for quite some time. And they find they have to sleep more often, that they just do not have the energy to participate in normal activities. They can get skin changes in both the pelvic region, the vulva, which can be red, they can get itchy, and they certainly have an increased probability of getting fungal infections which cause discharge and itch. They can get a vaginal discharge. They can get diarrhoea. Diarrhoea will upset people within their sexuality because they're not sure what's going to happen with their bowel. It's not only just loose stools, it's knowing what's happening, whether it's going to happen now, suddenly tomorrow, in the next 10 minutes, in the middle of having intercourse. They're really quite concerned about it. And one of the things about radiotherapy is that very often it's hard to know exactly when you're going to have your bowels open because the messages get all a bit mixed up. And it is important that you talk to patients about it and talk about managing this with medication. Women have been reported to suggest that they get dissatisfied with sexual activity after they've had radiotherapy. It's a combination of all things, but they're not happy. And relationships need to remain supportive and satisfactory as patients are having their treatment. But in the long term, if you've got a good relationship with your partner, they end up with maintaining that relationship into the future. Fertility. A big issue in young women. Unfortunately, unlike Ari, I can't spare anything, and most of them, anyone who has radiotherapy to the pelvis, if they've got their ovaries intact, will cause damage, very low dose, even from, as Ari has pointed out, scattered internal radiation, not a beam straight onto the ovary, but from internal scatter. It induces early menopause. The uterine lining, if it's intact with radiotherapy, will become very sclerosed and not able to support pregnancy. And even with hormone treatment, you can't guarantee that there will be recovery of that uterine lining. The use of dilators. We routinely, in our department, give out free vaginal dilators to our women, and they are recommended to be used routinely. However, there's actually no evidence that it works. There's been no real randomised studies, and I have to admit my 84-year-olds get quite a hoot and a giggle about it. And I then tell them that Dr. Paramassivam would like them to use dilators because it makes his follow-up easier. And they say, really? I say, yes. So we get onto it and we give them to them. But there is no evidence to suggest that it works. However, there have been observational studies to suggest that it will help with sexual activity afterwards with long-term follow-up. But the problem with the observational studies is that the women who are interested in sexuality and sexual activity are often younger and more active and are much more likely to be active with their vaginal dilators than the 85-year-old who really isn't interested in sex. And so we're really not sure if you take two 45-year-olds and give them vaginal dilators, that one with and one without, that it works. But it would appear that if you give a woman who's motivated a vaginal dilator to use, that she can maintain a good vaginal length and activity so that she can have adequate sexual intercourse. But it is anecdotal and it's not randomised. Breast cancer. The other big area of women that we treat are breast cancer. Radiotherapy is involved in up to 80% of people who have breast cancer. And breast cancer has, over the years, changed considerably. When I started many years ago, a diagnosis of breast cancer was often equated with that you would die from it. But this has changed completely. We now have good screening programs and we present with early disease, but also on top of that, metastatic disease, because it can be managed with both hormonal and effective chemotherapy, has become a very chronic illness. Women live for many years with their breast cancer. And therefore, the concerns with their body image become much more important because they've lived through the life-threatening illness. Chemotherapy and radiotherapy make a difference to the way you feel about yourself. Acute side effects such as the fatigue, the very sunburnt skin reaction, the breast swelling, and the neuralgia that they get from axillary dissection will recover as time passes. But problems with sexual functioning and fertility after cancer are not only common, but they are likely to remain for many years, and that includes women with breast cancer. It is widely recognised that women's sexuality can be particularly complex after breast cancer. You've got the impact of the treatments, the diagnosis, depression, psychosocial impact, stopping work for a while, all the things that make you feel that you're important as a person. These impacts can last for many years, even after you've had successful treatment, and therefore it's very important that support and discussion about these issues be had with these women. The fears that they have are a fear of loss of fertility, negative body image, feelings of sexual unattractiveness, loss of femininity, depression, anxiety, and alterations to their sense of their sexual self. I often ask my women when they've had breast cancer, who've actually looked at themselves in the mirror, and the number of times you get a no answer is surprising. And how have they altered their behaviour with their husband for sexuality? They wear something in bed, and that's the way they feel about it. So it is a big issue, and we need to be more aware of it and try and help deal with these issues. But if you look at some retrospective studies with psychosexual adjustment, body image and sexual functioning with breast conservation or reconstruction, this was a women's study with 146 women, they showed that most of the women didn't do too badly if you've got a breast, and that they managed reasonably well with overall illness, body image, etc. Their partial mastectomy was better than reconstruction in terms of pleasure and frequency of breast caressing during sexual activity. Chemotherapy really knocks people around, and women find it very difficult, and they do not recover as well as women who've just had hormonal therapy with radiotherapy. It's the same group. I'm going to tell you a little bit about the boys. The main thing about men is that we talk about erectile dysfunction. It usually occurs after both surgery and radiotherapy, and often after radiotherapy the erections are just not firm enough to have adequate sexual intercourse for penetration. Other factors contribute, such as smoking, hypertension, diabetes. What happens is that you get blood vessel changes in blood, with the reducing the flow of blood to the penis, and that's why medications such as Cialis, etc., can be helpful. The hormones and the desire for sexuality when you've had prostate treatment are not changed, and this is where it can be an issue of management. The other thing that happens if you treated the prostate, whether you've taken it out or whether you give it radiotherapy, is that you dry it up, and they get dry ejaculation, and they get or they'll get reduced volume. And when you talk to patients about it, they say to you it feels different. It's not the same, and they find that quite disconcerting at times. The radiotherapy takes a while to have its effect. It's a slow process of fibrosis over several months to years. And even things like brachytherapy, external beam radiotherapy, the erectile dysfunction over a long period of time, if you look at 5 years, still remains very high. That's from a paper by Podolsky. Sexuality for males in our society, though, is often defined by erectile dysfunction, but sexual desire and pleasure remain normal. And so it's important, if you can, to encourage alternate pathways for orgasm despite not getting an erection. And it's important to encourage intimacy and support and communication between the partners in the relationship. Fertility. Sperm don't like radiotherapy very much at all, nearly as much as ovaries, about 6 gray, and you can knock off most of them. External beam radiotherapy, because of the internal radiation, even if you shield the testicles, it doesn't stop the internal radiation, and they will result in a low sperm count. And in men under 50, it may recover, but it's not likely to in the older age group. And it can take up to 12 months, and radiotherapy shouldn't be used as a form of contraception, as I reminded one of my patients who told me his wife was pregnant after 9 months. But I had warned him. And you should not have a pregnancy within 12 months of radiotherapy to reduce the risk of genetic changes in the fetus. Most men that I see having prostate cancer treatment don't want children, and they almost laugh me out the door when I talk about fertility, but it is something that should still be raised. I want to mention something else that occurs, which isn't talked about very often, is this word orgasmalgia. Just about finished. This is actually pain occurring at orgasm. It occurs whether you have brachytherapy, low dose rate, or high dose rate. It usually resolves but takes months. You need to discuss it and warn your patients about it, and it can upset a sexual relationship because right at the time of orgasm when it should be, and ejaculation when it should be the best time, it hurts like hell, and it's very uncomfortable. It does get better, but it can be very frustrating and difficult. So radiotherapy is involved in the treatment of 50% of cancer patients. Side effects are very significant. Emotional issues always interact with the physical and may aggravate sexual difficulties. Awareness of issues, allowing patients time to discuss their concerns, is really important. And in some cases you need to be proactive in discussing the issues and actually raise the issue rather than just let it flow on. And thank you very much for your attention.